Good evening. My name's Rob Duffy. I'm the senior lower limb physiotherapist at On Recovery at the Keep Clinic, working alongside Professor Lee. A keen interest in knees, particularly ACL rehab. We've been using MADUP now for some time in the rehabilitation of our patients. And this evening, we're just going to look at some literature to support what we feel is quite evident in clinic with the results that we're getting. So this is the study that we're going to look at. It's comparing the effectiveness of blood flow against high load resistance training in post-surgery ACL. The interesting thing about this study is that it was done in the UK National Health Service. Prior to this study, only 2 had been completed looking at the effects of BFR in ACL reconstruction. Everson et al. Demonstrated that BFR did not reduce any extensive cross-sectional atrophy in the first 2 weeks post-ACLR, but the likelihood of that was that the 10% max strength required to induce hypertrophy wasn't achieved by the isometrics and straight leg raise protocol that they used at the time. Then Otar et al. Showed that blood flow restriction significantly greater increased in knee extensor muscle size and knee extension and flexion strength compared to light load training. There was no difference in the range of movement or laxity from pre-surgery to post-training in that trial, demonstrating BFR was safe to use without compromising the graft healing. Then this paper that we're looking at now was aimed to complete a more holistic, complete study to investigate the effectiveness of BFR in improving skeletal, muscle hypertrophy, strength, physical function, pain, and effusion. So this one is a lot more complete and a lot more outcomes, so to speak. It was a very in-depth paper, and I'm sure Hughes and his team worked really hard to get all of this done and completed. So the overview, like I said, it was done by Hughes et al. In 2019. It was an 8-week program completed in an NHS setting, as previously mentioned. It was a parallel group 2-arm single assessor RCT, and there at the bottom are the 4 main outcomes, along with range of movement that they looked at throughout the course of the study. So included in the criteria, there are 28 patients. Each of them had unilateral ACL repairs with a hamstring graft. The patients needed to be active, non-smokers with no neurological, cardiac, pulmonary or metabolic conditions. Excluded from the trial, anyone with previous ligament ruptures, traumas, any significant comorbidities that might have an impact of the contraindications of BFR, like a history of DVT or vascular pathology, anyone who had injections into the knee in the previous 6 months, anyone using anticoagulants, and obviously unable to follow instructions were excluded. So the trial protocol was, it was 1 familiarization session and 4 experimental testing sessions. The first was done pre-surgery. The second was completed post-surgery at week 0. Third was done mid-training between weeks 4 to 5, whilst the 4th experimental testing session was completed post-training at week 9. 2 weeks post-op, once the surgeon had approved that it was okay to start and the sutures had been removed, the patient was then assessed every 2 days to determine if the starting criteria had been met. Once all criteria was met, the participants proceeded with post-surgery experimental session. And the criteria was that the patient needed to unilateral weight bear for longer than 5 seconds without support, have a range of movement of 0 to 90, straight leg raise with no extension lag, and active hip and knee flexion. Also, in the criteria was a minimal effusion change with activity. And again, just going over what we've touched on is a nice flow chart on their inclusion exclusion criteria and the protocols, etc., set out in a flowchart format. So the resistance training intervention, it was 2 sessions a week, minimum of 48 hours between each session, containing a 5-minute warm-up of unloaded cycling, 10 reps of unilateral leg press with a self-selected weight, and that was performed throughout the range of 0 to 90 degrees of knee flexion and extension. A 10 rep max strength used to reliably predict a 1 rep max strength. The injured limb was always trained first, followed by the uninjured. And the load increased by 10% if all reps completed on 2 subsequent sessions. And the load increase was worked out by the exercise volume was the number of reps times the load. So it was similar, it was the same in both groups. One was high load resistant training, one was BFR training. So both limbs were occluded, and occlusion was automatically calculated, set at 80% limb occlusion pressure. And the nice thing with using the device is that it increased cuff pressure by analysing pneumatic pressure at each increment, providing consistently accurate occlusion pressures. So in multiple segments throughout each rep, the machine is calibrating and giving constant feedback. And again, muscle strength was tested. 5-minute warm up on the bike, unilateral 10 rep max leg press, and that was put up in 5 kg increments, added if achieved within 5 attempts. There was 3 minutes between each rest to ensure recovery. Further to this, knee extension and flexion were measured on an isokinetic dynamometer with 5 max efforts of knee flexion extension through full range at 60, 150 and 300 degrees a second. So when Hughes was looking at muscle morphology, muscle thickness, pennation angle and fascicle length, the vastus lateralis of the injured limb only was assessed using ultrasound. The cross-sectional area of the vastus lateralis represents the largest area in the knee extensors. And imaging was performed by the same assessor each time to minimize bias. Muscle thickness, the centimeters, distance between superficial and deep aponeurosis of the widest point. The penetration angle was between the fascicle and the deep aponeurosis. And the fascicle length was the insertion of deep fascicle into superficial and deep aponeurosis. Taken from 50% of the distance of the ASIS to the superior pole of the patella. Again, that, as mentioned earlier, represents the largest cross-sectional area of the vastus lateralis. Once a clear image was achieved, it was frozen and the average was taken from the 3 images. Physical function. So the International Knee Documentation Committee, subjective knee formed to assess symptoms and function of ADLs. That was measured at 0 to 100, 100 given as the highest knee function. The knee injury and OA outcome score it took into consideration all them following bits that are mentioned after it. That scored of a 0 to 4 and then transferred to a 0 to 100. So 0 would be extreme symptoms, 100 being no symptoms at all. The lower extremity function scale, 20 questions on ability to perform everyday tasks, again scored from 0 to 4 with a maximum score of 80. Interpreted as a percentage, the high percentage was then translated as closest to your maximum function. The Tenga, 0 to 10, 0 was disability, sick leave from work, and 10 scoring participation in national or international league sport. And then the dynamic postural control using the star excursion balance test, anterior, posterior medially and posterior laterally, 3 in each direction. The nearest 0.5 centimeters was taken on each one, and then the average was taken. Pain was measured by the knee injury and osteoarthritis outcome score pain scale. 0 was extreme pain, 100 was no pain. So increased pain score equaled pain reduction. So the higher the score, the less pain you were getting. Range of movement, a goniometer was used. The patient was supine with a heel elevated on a foam roller. Knee extension, maximally extended knee, and defined as the difference from 0 degrees extension. And then flexion was measured by bending the knee and sliding heel to the buttock. Side to far side differences were scored by taking away the injured score from the non-injured limb. They measured supine by the patient again being, they measured effusion by the patient being supine. Mid-patellar joint circumference measured in centimeters to the nearest 0.1 centimeters were taken, and again, an average of 3 scores. Laxity, knee joint laxity during the trial, again, supine 30 degrees knee flexion, and the ligament laxity was assessed using the KT 1000 knee ligament atherometer to the nearest millimeter. So results of the study showed, various different things. The total exercise volume was higher in the BFR group, and whilst the load is higher in the high load resistance training group as expected, the percentage change at week 1 and week 5 to 8 is greater in the BFR group, but statistically significant in both interventions. So very interesting to know that whilst the heavy load is obviously they're training heavier loads, exercise volume was greater in the BFR group, which is great for someone who's this early in ACLR. There was no statistically significant interaction for either limb. From pre to post surgery, 10 rep max decreased in the injured limb, but was maintained in the uninjured limb with no group differences. Through 8 weeks of training, both interventions produced significant increases in 10 rep max strength in both injured and non-injured limb, respectively. And that is the figures below that we're looking at. Isokinetic strengths, the pre-surgery to post-training, both groups demonstrated a decreased knee extension peak torque at 60 degrees a second. The high load resistance group demonstrated a significant decrease in knee extension at both 150 and 300 degrees, whilst BFR showed no significant change. So very, very positive there that the high load group had a significant decrease, but the use of BFR maintained the movement at 150 degrees and 300 degrees, suggesting that the BFR works well to maintain fast fit fibers post-op, as Professor Lee had mentioned earlier on. Knee flexion, greater decrease in patient was observed in all speeds of high load resistance training group compared to BFR. So again, really highlighting the fact that the BFR group is doing considerably well. And we've got just some cluster charts here showing, pre and post, pre-op and post training, and the results of the injured and non-injured limb at 60 degrees. 150 and the 300 degrees. So yeah, there's some nice improvements made there through BFR. The muscle morphology from pre to post surgery, both groups experienced significant decreases in muscle thickness, pennation angle, and fascicle length. As we would expect someone to go, post-op. Following 8 weeks, both groups experienced significant increases in muscle thickness and penetration angle, respectively, but there was no change in fascicle length. Physical function, as expected from pre to post surgery, all self-reported measures significantly decreased in both groups. However, following the 8-week trial, significantly greater increases were seen in the BFR group with self-reported measures. And again, a graph here with lots of numbers and figures on, but all the IKDC, the CUS, the lysome, everything that we've mentioned earlier, and the numbers really that are crunching there between the BFR and the high load resistance group. Weeks 0 to 4 on the left, weeks 4 to 8 in the middle, and then the overall mean difference throughout the whole trial on the right hand side. But looking into them, there are some really interesting figures in there on what BFR is doing and achieving. Now, the STAR excursion balance test was the functional movement test. From pre to post surgery, all reach scores significantly decreased, but over the course of 8 weeks, there were significantly greater increases in all reach scores with BFR. And again, the numbers here to back that up, anteriorly, posterior medially, and posteriorly laterally, the BFR and the high load resistance, if you look at them and spend some time sort of crunching them numbers, you will see that there are significant changes again in the BFR group, specifically in the injured limb, as we would hope to see. So with the range of movement, there was no change in extension differences throughout the study. There were statistically significant group times time effects for full extension and range of movement differences. From pre to post surgery, full extension difference and range of movement significantly increased for both groups. But over the 8 weeks of training, BFR provided significantly greater decreases in full extension differences and range of movement. From pre to post surgery, the CUS pain score significantly decreased with no group differences. And again, there was a significant group times time interaction involved. Over 8 weeks, significantly greater increases in the CUS score with BFR. And this can quite possibly be attributed to the lighter loads used compared to high load resistance training. Effusion, from pre to post surgery, mid-patellar effusion increased significantly with no group differences. Again, totally expected, and what we'd expect to see for someone who's undergone this type of surgery. And again, there was significant group times time interaction effect. But over 8 weeks training, there was a significantly greater decrease in mid-patellar circumference measurements for the BFR group. The laxity pre-surgery to post-training, side-to-side laxity significantly decreased in both BFR and HLRT groups. And they're just the figures there to back that up. So concluding, BFR and HLRT elicited comparable increases in skeletal muscle and hypertrophy and strength. The BFR group has resulted in greater improvements of physical function and range of movement and greater reduction of pain and effusion. Neither intervention had different effects on laxity, which was again in line with the previous study done. And therefore BFR is more appropriate in the progressive limb loading phase of rehab following ACLR within this setting. Again, we're looking at the improvements throughout as we're concluding. The improvements in the STAR excursion balance test was significantly greater with the BFR group. Now, is that down to greater reduction in pain, effusion, which will lead to a better range of movement? The CUS, a far greater reduction from 67% in the BFR group compared to 39% in the high load resistance training group. And again, together, a greater reduction in effusion, 6% to 2% respectively, a reduction in pain may have contributed to better improvements of range of movement. So all this may be attributed to the lighter loads, as mentioned earlier, during BFR in the early stages. and again mentioning importantly without the detrimental effects of hypertrophy and the strength improvements that are really important at this stage in the patient's rehabilitation. Thank you for listening, and if you've got any further questions on tonight's presentation, then please feel free to drop me an email or contact me on LinkedIn. I'll do my best to get back to you. Thank you very much.